Kia ora everyone and welcome to this Goodfellow webinar, kindly supported by GSK. Let's get real about asthma management. My name is Dr. Grace Lee. I'm a general practitioner and tonight I'm talking to Dr. Andrew Corin, who is a general practitioner with a subspecialty interest in respiratory medicine. He's also a clinical researcher and an award-winning author. All right, Andrew, over to you.
All right, thank you, Grace, and I appreciate the introduction and to the Goodfellow team for the opportunity to present to my colleagues. And to those of you who've logged into the webinar, I appreciate the time is very precious, and I appreciate you sharing your precious time with me. I trust it'll be a good investment over the next 45 minutes or so. I want this to be more of an interactive conversation or discussion, as Grace has suggested, from one GP to other primary care clinicians, albeit limited by technology. But I've been working at the coalface of general practice as a clinician and as a business owner for some 22 years, and I really appreciate the opportunity to share some of the things I've learned with my primary care colleagues. And I also appreciate the opportunity for you to feed back and to share your thoughts through the course of this presentation. So please do that. Grace has a very important role as the moderator to share your thoughts and questions with us as a group. I encourage you to do that. Now, I will put up a number of slides tonight, and rather than apologize for that, I want to explain my purpose. The Goodfellow archives will have this presentation and the slides for you to refer back to and unpack in some detail and at your leisure in your own time. And one of the things I want to do with this presentation is present a suite of information that you may find familiar, and maybe some things that you want to dive into a bit more deeply. And the slide deck will be there for you to do that. I came across a quote just this last week from an American poet, Eugene Peterson, that resonated very deeply with me. The quote from him is, "Hurry is a form of violence practiced on time." Hurry is a form of violence practiced on time. And as I say, as a GP who seems to be constantly under time pressure because I feel under-resourced and over-demanded, I am hurrying a lot. And so that reminded me to just take time. And I think for a lot of us, if not all of us, through the pandemic lockdown, we've been forced to take time and to reflect and to slow down. And I think it's been good for us to do this. And the message about treating time carefully is very relevant to this presentation as well. So I don't want you to feel hurried through the presentation, but rather invited to spend more time with the slides later. I want to declare that I've received an honorarium for this presentation from GSK. I don't believe this list of disclosures unreasonably biases my presentation tonight, but you are the judges of that. The intent instead is to draw on my 22 years of general practice experience and clinical trial work with asthma to consider the prescribed medicines and other strategies that we have available to frame up a real or pragmatic approach to asthma management. These are my conflicts of interest, which I think are perhaps more relevant as distractions from my usual role as a GP. I'm fortunate to live and have done so for many years in the Bay of Plenty, and writing, travel, adventures in the great outdoors, music, and growing avocados feature very prominently in my distractions. But I want to begin tonight by framing this presentation around a patient. We as clinicians are pragmatic, and the theoretical lessons need to have some practical clinical relevance. So this patient, Carmen, we'll encounter through the presentation. I met her a few years ago in her 60s. She had a diagnosis of asthma, having been made when she was 39, but she did report that she'd had symptoms since childhood of asthma. She suffered from very brittle asthma. She'd had a history of ICU admissions for her asthma, and she knew her triggers and the usual cascade of a crisis that would lead her to an ICU admission. She was quite aware of her condition. Unfortunately, Carmen had had no prior spirometry when I first met her, and the lack of significant reversibility when performing spirometry, even when I'd stopped her inhalers, coupled with her normal FEV1 FEC ratio and her history of smoking, made the precise diagnosis of her condition challenging. She was also a fairly typical older patient with multiple comorbidities, and of note was her head injury and her associated anxiety. The outline for the next 30 minutes will involve some looking back, some considering where we are now, and having a view to the future. I'm a big fan of valuing and knowing our history, and Lord Acton, the English historian, politician, and writer, who's perhaps best known for his statement that power corrupts, absolute power corrupts absolutely, also made this statement about the value of history. And one of my favorite philosophers, Soren Kierkegaard, has said, we live life looking forward, we understand life looking back. So briefly, let's have a look back at our asthma history. 3,500 years ago, ancient medical records have detailed herbal knowledge of plant extracts containing adrenaline being used. Oh, excuse me, that was the cleaner just popping in to do the job. He'll leave us till later. But adrenaline was extracted from tea leaves and boiled up and used as an inhalation for bronchodilation. Of course, we still use this application in severe asthma today. The grandfather of medicine, Hippocrates, first gave asthma its name. Asthma is a Greek word which means panting, and he linked it to environmental triggers and particular occupations in his own time, becoming an advocate of precision medicine, I think. 500 years later, Galen, a Roman physician who is best known for his descriptions of human anatomy, he was the first to define asthma as being caused by bronchial obstruction. And he used owl's blood in wine as a treatment, which escapes me for a pharmacokinetic method, but he used it, and he was a very wise man. Moses Maimonides, the Jewish physician, 1,000 years later, was the physician to Saladin in his court. And Saladin's son suffered from asthma, and Maimonides wrote the definitive ancient tome on asthma. And his remedies included personal and environmental hygiene. We're very familiar with the value of that now. Sleep and chicken soup. Perhaps this is where that great remedy started. Charles Dickens wrote in the 1800s some of the best known novels and fictional characters, and he suffered from asthma, diagnosed when he was older, and he smoked opiates for relief. And you can read the extract from David Copperfield, which describes the panic of an asthma attack, which is familiar to all of us, having seen it, if not experienced it personally. And of interest and concern, just 100 years ago, our medical colleagues recommended smoking tobacco as a treatment for asthma to help relax distressed breathing. And we know how bad that advice turned out to be. Our psychiatrist colleagues 70 years ago gave their spin on asthma, and it's described in this critical review, which I'll read an excerpt from. You can see it arrowed there. What is the physician to believe? That an asthma attack represents a cry of longing for the mother, or simulates an orgasm, or results from repressed hostility? Is he to refer all his asthmatics to a psychiatrist or employ a psychologist in his clinic? Thankfully, soon after this, the inflammatory model of asthma was described and embraced. And the slide here is complex, not here to be reviewed in any detail, particularly at this time of the night, but rather it's there to highlight the cascade of inflammatory pathways that drive asthma and the many potential levels for therapeutic intervention which have been explored since this time and which continue to be the focus for drug development. Since the 1960s inflammatory model was described, we've seen much development in asthma therapies, many of which form our current arsenal. Beclomethasone dipropionate in 1972 was introduced as the first synthetic corticosteroid asthma controller administered via the inhaled route. And this was a massive breakthrough that freed asthma sufferers from the fear of adverse effects associated with chronic systemic corticosteroid use. And since then, over the timeline, you can see that many inhaled corticosteroids have been approved for clinical use with a wide range of glucocorticoid receptor selectivity, potency, pharmacokinetic parameters, and inhaler formulation options. Back at the beginning of the timeline, you can see there in 1969, the advance of an inhaled bronchodilator, and this remains the most widely used single treatment amongst asthma sufferers, despite advances in treatment recommendations and therapies, and we'll address this outdated and potentially harmful treatment approach shortly. The timeline shows the progress of inhaled therapies, device development, the development and application of guidelines, the rise of biological agents, and most recently, the recognition of a precision approach, which we will look at shortly. So it would appear, looking at this, that there's been much progress in asthma management over the last 50 years or so. However, we have some major challenges facing us. We will look briefly at the issue of ongoing poor perception and control of asthma. As a result of poor control, there are unacceptable levels of complications from asthma. I think as clinicians, we can do better with the quality of our diagnosis and refining this. The perennial problem of poor adherence remains a challenge, which we need to keep front of mind as a priority. And tied in with this are the high levels of critical errors in inhaler use. A patient may well be prescribed a good therapy, but often little of it ends up in the lungs, exerting an effect. Now, I think we've all seen a version of this slide on many occasions with asthma talks. We know that asthma is an important disease in New Zealand with significant impact on adults and children, high hospital admission rates with unacceptable mortality, and associated with that, high economic cost. Māori and Pacifica people are disproportionately represented in these figures, and in spite of New Zealand's history of leading the world in asthma research, we have the dishonor of having the world's 4th highest hospital admission rates for asthma. The concerning paradox is highlighted in this paper, where despite advancing knowledge and therapies for this 10-year period between 2006 and 2016, globally there was no change to asthma mortality rates. This is despite the costs of therapies escalating and having a lot more to choose from. For that 10-year period, global mortality did not change, and there's no reason to think that that is any different in these recent years. This signals to us that something is wrong. I was present at the European Respiratory Summit annual conference in Milan when this Lancet paper was presented to much debate, and we can feel proud that some of the lead authors on this paper are our New Zealand colleagues. And the purpose of the paper was to respond to the paradox in static mortality by thinking about what's wrong and how to respond. And I think each of these points deserves to be spoken to. Clearly, I believe we need a revolution in thinking about asthma and being more precise in how we treat it. There's a need to move beyond a disease control approach and think more about disease prevention. It's important to emerge from our silos and become much more integrated and collaborative in how we manage these patients. Testing is really important. If we're going to embrace precision medicine and precision treatment of asthma, which I'll talk to shortly, we've got to have a target. We need to be testing more. There needs to be a zero tolerance for attacks. We know that asthma attacks cause irreversible damage to the lungs. It's unacceptable to be having attacks, and we need to be finding ways to minimize this impact. There's some exciting development in severe disease, and we'll touch on some of those developments shortly. And also we need better research, and again, we'll touch on this in the presentation shortly. Asthma is not simple, and don't be overwhelmed with this slide. I have colleagues that I encounter who think that there's nothing new to learn about asthma, and it's simple, and I contend that they are very wrong. The traditional one paradigm fits all treatment approach, I think, is simplistic and limited. Not all asthma is the same, and there can be discordance between inflammation and symptoms, which in turn should drive a refinement of treatment approaches. So the purpose of this busy slide is simply to reinforce the complexity and to encourage us to start thinking about more precise and targeted ways to treat our asthma patients and find their place in this complex paradigm. This is a review article from just a year ago, which highlights the same sort of thinking, the need for a paradigm shift in thinking about obstructive airways disease. The highlights from the review article is that the model of asthma as a single entity has been replaced. And we need to be thinking about the complexity of asthma with an umbrella diagnosis that can then be unpacked into the distinct endotypes and phenotypes within that. And this in turn will drive us to be able to make better diagnoses and target more appropriate therapies to our individual patients. You may have heard the term treatable traits, and I hope it's becoming a more familiar part of our conversations and thinking about asthma in our patients. Treatable traits are defined pragmatically. They must be relevant to the patient, they must be identifiable in a clinical setting, and they must be amenable to treatment. And these treatable traits, whilst many of them are in the lungs, they're not limited or confined to the lungs. And this approach, considering the treatable traits both in the lungs and in the wider person, encourages a whole patient assessment, having a systematic approach and refining the treatment options down to getting something that's precisely right for that particular patient. Now, I do find this slide particularly helpful for me when I encounter a difficult to treat asthma patient or somebody whose control is not great. This just helps me think about some of the treatable traits that I can be considering. In this particular slide, just to highlight the difficult to treat down to the possible to treat doesn't describe the patient, but it refers more to those particular traits and how easy or amenable to treatment they are. Part of the transformation and revolutionary thinking addresses nomenclature. We can all think of some of our patients who simply do not fall easily into a diagnostic box of asthma or COPD, but our therapeutic choices are often quite constrained by the need to make such a distinct diagnosis. And the international recommendation from leaders in respiratory disease is to think of obstructive airways disease as the umbrella term, and then refine the diagnosis with precision using the concept of treatable traits. Those treatable traits which are most relevant in asthma, and in particular in the lungs, are eosinophilic airway inflammation as a driver of exacerbations, and the prevalence of symptoms due to airway or airflow limitation. Our colleague in Wellington, Richard Beasley, and Ian Parvard from Oxford are amongst the world's leading experts in this field of considering treatable traits. And Professor Parvard presented at a severe asthma forum in Auckland back in February this year. He is passionate in recognizing that primary care is where the key management decisions are made. And so we primary care clinicians need to be looking for the relevant biomarkers to use for targeted precision medicine. We know in cardiovascular medicine or in diabetes, for example, numbers are really important and we treat to those targets. We tend not to focus on numbers so much in airways disease, and this is an area that we need to think differently about. Blood eosinophils are one of the most important in that they are a very relevant surrogate for airway eosinophil levels, and as those blood eosinophils increase, they drive the risk of exacerbations. So let's come back to Carmen. She was on a good combination ICS LABA inhaler and reported that she used it regularly and used it well. She had her bronchodilators to use, her allergy medicine, and the medicines for her other clinical conditions. Her social history is important in that she was going through a pretty difficult time at home, and she had a known history of mental health decompensation in these stressful situations, and smoking was something that she tended to do when she was suffering stress. So up until a year ago, She'd had a good run for 18 months, but coming into the middle of winter, she developed an upper respiratory tract infection, probably viral, and triggered a cascade of her asthma symptoms, which she recognized quite quickly and got herself off to hospital. She was treated in the standard way with, you'll see, intravenous adrenaline, that 3,500-year-old remedy, along with the other standard treatments, and received a prolonged course of prednisone and antibiotics on discharge. A month later, she was served with the separation papers by her husband, and this caused her significant distress, and her smoking increased. A few weeks later, she had another exacerbation of her asthma, recognized she was in trouble, got the ambulance. The ambulance needed to deliver adrenaline in transit, and she arrested twice in the ED and had a prolonged stay in the ICU. When I received Carmen's discharge letter, it caused me some significant pause, because this was a disaster for her. And I wondered what I could have done differently, what we as a clinical team could have done differently for her. Considering her treatable traits and biomarkers, she certainly did have moderate airway eosinophilic inflammation based on her blood eosinophils of 0.4. She had airflow limitation. She was smoking again, which we knew was a potent trigger for her, and her anxiety and stress with the social crisis were driving her ill health as well. She was already on high-dose inhaled steroid therapy. I don't think there was much room to increase that. The evidence is fairly clear that you don't get much benefit from increasing beyond the dose that she was taking. But what we could have been more intentional about was attending to her adherence and technique, and actually checking that and finding ways to assess that better. Perhaps we could change her inhaled corticosteroid. We could add a long-acting muscarinic antagonist, not funded in New Zealand for asthma patients, but that is a recognized option for her. And also we needed to be more intentional about focusing on her smoking and supporting her mental health and her social situation. The GINA guidelines are an important centering point in this presentation. The strategy from GINA has twin guidelines, or twin goals, I should say, of controlling asthma symptoms and reducing the risk of future adverse outcomes. So control symptoms, reduce future harm. Based on compelling research, the bulk of which was from New Zealand-based trial centres, ours included, which we reported in the New England Journal of Medicine and Lancet in 2018 and 2019. The GINA guidelines group made an important change at step one. So step one in the guidelines used to have, as needed, short-acting beta agonist. But the result of our studies showed that this exposed mild to moderate patients to a higher risk of exacerbations than if they were taking low-dose inhaled corticosteroid. And as a result of this data, the guidelines group made this important change last year, so that all patients with asthma, whether they are mild, moderate, or severe, they should all be on inhaled corticosteroid. There is no place for SABA alone. I'm a strong believer in the importance of aiming for total control. You'll remember that earlier slide that we don't want to just control, we want to prevent, and we need to be preventing the permanent damage that happens in lungs from every asthma attack. So total control is our ultimate goal. And this can only be achieved by daily maintenance use of an ICS. Symptom-driven management, such as PRN, budesonide, formoterol, is less than this ideal, but it does recognize that many patients, for different reasons, are not going to be adherent to daily dosing. And I think the value in having a number of different inhalers with varying delivery devices and actions means we can tailor the best treatment option to the specific patient. But once again, the key message here is that ICS is advised at all steps. So I've described the history of asthma management, which has moved through treating symptoms to identifying triggers, and then targeting pathogenesis, and which has led to the current environment of recommending ICS for all asthma patients with a range of agents and delivery systems to choose from. patient perception of control is often very poor, as is adherence to medicine. So where do we go to from here? Now, before moving forward, we need to ensure that we're getting the basics right. And this slide shows a three-phase approach to address the gaps in patient care in light of what we know. And the first step there, engage patients. It's simple, but I think often perhaps overlooked. Our patients are the key stakeholders in our clinical relationship. They need to be valued as such. And this includes taking time to understand their health literacy, their social systems, their perspectives and priorities in managing their condition, and providing appropriate education and support. And of course, this takes precious time. And so our clinical teams become important in sharing this responsibility and making use of continuity of care and communication tools and strategies. Concordance is key. Concordance as a term, it's not synonymous with either compliance or adherence. Concordance doesn't refer to a patient's medicine taking behavior exclusively, but rather the nature of the interaction between the clinician and the patient. It's based on the notion that consultations between patients and clinicians are a negotiation between equals. How individual patients value the risks and benefits of a particular medicine may differ from the value assigned by their clinicians. And in adopting a concordant approach, clinicians should respect the rights of patients to decide whether or not to take prescribed medicines. The aim of concordance is to establish a therapeutic alliance between the clinician and patients so that we can find our common ground. And it's synonymous with patient-centered care. We need to make use of the wide range of tools that are available to help improve health literacy. There's no point reinventing things. There's a lot of good material out there. And we need to engage with other educators in this process as well, whether they be nurses, pharmacists, community educators, family, whānau members, and so on. There are a lot of resource that we can tap into. And consistency in the messaging, I think, is really important. Patients, if they're going to agree to a plan, we need to be consistent in what that plan looks like. And this is where an action plan can be a simple but powerfully empowering tool for patients. Clearly, if control is the goal, and I believe it is, we need to be able to assess this in a robust manner. It doesn't come as a surprise that with poor health literacy skills, many patients actually do not know what is meant by asthma control. And in this particular study, regardless of how asthma frequency was described, a high proportion of patients believed their asthma was well controlled, even if they were having symptoms every day and through the night. Almost 80% of those patients felt their asthma was controlled. How do you assess asthma control in your practice and in your patients? If you reflect on this, such an assessment, I think, falls into three broad categories. There's the history that's reported by the patient. To be honest, not entirely trustworthy. Patients are prone to tell us what they think we want to hear. We can look at prescribing data using e-prescribing platforms that are increasingly available to us, but I find the quality of information that comes from those platforms is variable. Questionnaires tend to be the place that we land for assessing control, and there's a wide range of these tools. The ACQ, the ACT, the St. George's Respiratory Questionnaire, the ASQ, the 30-second asthma test, and we'll look at one of these that I use regularly in my practice, which is the ACT, or the asthma control test. It's widely researched, it's been around for a long time. It's found its place both in research and in clinical practice. It's easy to use, available for adults and for children, and in various languages. And it has 5 questions which address the important domains of asthma control. And these 5 questions can be easily answered within a minute. The scores from answering these questions are well validated and correlate with the risk of exacerbation and the health impact. And so the ACT score as a predictor of exacerbation risk places the key threshold there at about 20. Below 20, the risk of an exacerbation goes up. Over 20, your control is good. And you only need a small loss of control of 1 or 2 points below 20 to signal a significant increase in exacerbation risk. A few years ago, our team conducted this cohort study using the ACT as a tool to guide step-up treatment according to guidelines. And we demonstrated a 75% improvement with these patients moving from poor control to control simply by using this tool and existing medications. I'm not aware of very many medications making the pharmac threshold for funding which demonstrate this level of efficacy. And by step up, in general terms, this can mean medication adjustments, which formed our trial protocol, a change in delivery device, and attention to lifestyle issues. And I think these domains of stepping up treatment need to be considered every time we encounter somebody with poor control. So in a busy clinic setting where you've got limited time, limited resources to conduct a full asthma assessment, I believe the ACT can be used with confidence to assess asthma control and to guide asthma management. And it also becomes a very useful educational tool for patients to gain better understanding of what asthma control means. These are some cases from the step-up study, with one exception. This was a 29-year-old tropical fish breeder, very familiar with asthma because he'd seen it throughout his family. He was otherwise well, but he used his short-acting beta agonist often during the week. His ACT scores before the step-up phase of the trial were below 20. He was stepped up to an ICS, and his follow-up ACT score 3 months later was much better, and he made the statement that my asthma is the best it has ever been. This 37-year-old female high-performing teacher and athlete was using salbutamol often with her running and her seasonal allergies, and her control was not great with an ACT score of 17. We had a good talk about the importance of control. Health literacy for her was something that she wanted to improve, and she was interested, and she really engaged with the 3 modes, I guess, of the step up that we were looking at here, around medication, around device, and around her own behavior. And so she was stepped up to fluticasone propionate, and still has very infrequent need for salbutamol anymore. And she was genuinely surprised, this very intelligent, high-performing woman. She was very surprised at the concept of total control. She thought that having asthma meant she would always be limited. This is another 39-year-old woman with regular use of her short-acting beta agonist, with poor control as measured by her ACT scores. She was stepped up to an ICS, and at follow-up, her ACT score was actually poorer. And this just signals the limitation, or one of the limitations of the ACT. Just having 5 questions, sometimes it doesn't pick up the nuances of allergies and their impact on our function versus asthma. But she did say that her control overall was so much better on the ICS that she wanted to continue using it, even though her score at the time was marginally deteriorated because of her allergies. This is a 32-year-old office worker on medication for her IBS and using an ICS and short-acting beta agonist as needed. Her score was borderline poor at 19, and then we saw her for her second visit 3 months later with a score of 22, and she reported that stopping smoking had been the thing that had improved her control. She exited the trial. She didn't need to step up. She'd done that herself by stopping smoking, which was something that she has been able to maintain since then. This is a 45-year-old male, somebody I remember very clearly because he loved his football. He loved chasing the players and the ball around on the training field and on the match day field, but he was really struggling to keep up with play, and he was feeling very, very sad at the thought of having to give away one of the things that he loved. He used his bronchodilator most days. He had been prescribed an inhaled corticosteroid. He said, look, I use it when I remember, but to be honest, doc, I often just miss it. His control was very poor at 14 with a high exacerbation risk, and he was stepped up to a combination inhaler of budesonide and formoterol. At the review 3 months later, his score was significantly better and he was back into loving his football. We reviewed him 6 months later, still very stable, and suggested that maybe he could step down the dose that he was using to 1 puff twice a day. And he was reviewed again 6 months later, still well controlled, with really good self-awareness, and his adherence had improved. And I think a large part of that was down to the ACT educating him about how to control his asthma. This patient was not part of the step-up study, but I often will follow a similar approach in engaging with my asthma patients who have poor control to the protocol that we used with the step-up study. We assess control with the ACT, and if it's poor, we discuss issues of adherence, technique, and other treatable traits. I then review control after a period of time with the ACT, and if it remains poor, we consider a medication change with the appropriate educational follow-up. And this is the cycle you see in the GINA strategy and various management guidelines. We should always be thinking about the cycle of assess, adjust, and review. Assess, adjust, and review, and this worked out very well for this particular patient. So the third component of addressing the gaps is to look at evidence critically in collaboration with the patient. Remember, we're trying to be as concordant as we can in that therapeutic relationship, and then choose the best treatment for them. Regularly review inhaler technique and engage with secondary level services early before too much irreversible damage has been done. As of April the 1st, yes?
Sorry, just before we move on to the treatment, do you have any time for just a couple of questions?
I'd be delighted to field some questions.
Thank you. Now, with regards to investigation, you talked about how eosinophils were a useful marker. Is this something that you'd recommend as a part of your general workup for diagnosing asthma?
Yes, I think that all asthma patients should have a CBC done just to assess those eosinophils, because it can be a very useful guide for the role of inhaled corticosteroid dose. Remember that all asthma patients should be on an ICS, but the level of the eosinophils is a pretty confident marker of their exacerbation risk, and that can then guide our discussions from whether we're using PRN ICS LABA or whether we're using regular maintenance ICS and short-acting beta-agonist or LABA. Prednisone does impact on those eosinophil levels as well, so we need to be careful not to be testing too close to a prednisone course. Okay,
and what levels of eosinophils are relevant?
That's a very good question. In most trials, the level at which treatment changes are made is 0.3. In funding for mepolizumab, which is the monoclonal antibody that's indicated for severe eosinophilic asthma in New Zealand, that level is 0.5, which is relatively high. I think a large number of our asthma patients are atopic, and so we'll find that their levels are 0.2, 0.3, 0.4. And so I think in my practice, if I had somebody whose eosinophil levels were low, I'd be more inclined to use a lower dose of ICS, and somebody whose eosinophil levels are higher, I'll be more aggressive in getting them to a safe upper dose with their ICS.
Okay, and the eosinophils are posing a few questions in our audience tonight. And the last one on this is the timing of the count relevant? For example, should we be taking the test at the time when they're well or after they've had an exacerbation?
Yep, I think it's a fair question. I think that we know that when people have an exacerbation, lots of the markers, because of a few acute phase processes, will change. The evidence is that eosinophils tend to stay fairly stable apart from when they're exposed to systemic corticosteroids. So I wouldn't be too, we're usually seeing our asthma patients when they're unwell, and that's the time to take the blood test. With the exception of if they've been on a course of prednisone, we'd delay the testing of their CBC for 2 or 3 weeks, I would suggest.
Okay, so does this mean that you've talked about how prednisone impacts on the level of the eosinophils? What about intracorticosteroids? Does that have an impact at all in lowering the blood eosinophils if we have good control?
The inhaled corticosteroids?
Yes.
Was that a question? Yes. So no. So the systemic exposure from inhaled corticosteroids is sufficiently low that it doesn't impact on the eosinophil levels.
Thank you. And just before we move on, just got a whole swag of questions all at once, and we'll just do 1 or 2 more. Now, you talked about total control. There's just a question with regards to individuals that have seasonal asthma. Do they also require the intracorticosteroids as well?
So the simple answer is yes, but they may not need their inhaled corticosteroids all year round. The two options I would see for that type of patient are PRN, ICS LABA, or maintenance ICS, short-acting beta agonist during their seasonal period, with a very low threshold for reintroducing that ICS if their control is not perfect in the non-seasonal period. I think a big part of this comes to educating patients about what total control looks like, because patients, a lot of patients tend to accept some airflow limitation as being normal life for them, and that's unacceptable. They need to be aware that if they have any symptoms whatsoever of asthma, that's poor, and we need to be improving treatment. And in that situation, the only way to improve treatment with a view to reducing future risk as well as symptoms at the time is with an ICS.
Okay, and with regards to the ICS, we're talking about adults predominantly here, but is that applicable to children as well?
Yeah, very good question. The guidelines you may have spotted in the GINA slide, the guidelines are for patients 12 years and older, and that's because in the trials that we conducted, the novel and the practical studies, they were in the older teenager and adult group. We haven't got data at the moment to be confident with the role for PRN, ICS, LABA in children, and that work is underway. But no, that indication is really just for adults.
And with regards to some of the other tools that we use in primary care, for example, spirometry and peak flow, is there still a place for those particular investigations, or are we leaning towards more ACT and the blood test?
Yes. So we're wanting to find things that we can measure and monitor and review. And so we've got the ACT, we've got blood eosinophils. Spirometry is very important because, remember, we're talking about obstructive airways disease as an umbrella diagnosis, and then trying to be a bit more precise in defining what's going on here. So we need spirometry to be able to identify the degree of reversibility for a patient, but also whether or not they fulfill the criteria to be diagnosed as a COPD patient. So the spirometry has an important place. And I think that peak flow has a very important role alongside the asthma action plans, giving the patient the opportunity to be able to measure and assess their control at home and in their space.
Okay, and one last one before we carry on. Just from a practical perspective, whereabouts do you find that information sheet on ACT?
Oh, well, I've got some tear-off pads in my office that I source from my GSK rep for free. You can download them as a PDF off the internet, so they're very easy to access as an image off the internet, or the GSK rep would be very happy to supply them to you.
Great, thank you. I'll let you carry on.
All right. So let's move on. I'm just I got out of my flow here. So here, this slide just revisits some of the desirable features of an ICS. Over the last 100 years, we've had this quest to improve the potency and the selectivity and the therapeutic index of an ICS. And put another way, this quest to improve the molecules is driven by the goals of maximizing local effect while minimizing systemic exposure. So we want to maximize the effect in the lungs and have very little of the drug being exposed to the systemic circulation, which results then in a molecule that can be used at a low dose and with less frequent dosing. For patients with poor control, fluticasone furoate vilanterol may be an option which meets these goals. And I'm going to talk a little bit about this medicine for a few minutes now. Fluticasone furoate vilanterol is a combination ICS LABA in the ellipta device, and it's delivered through this ellipta device, which is quite novel, with a specific set of features that you can see there: once daily dosing, 24-hour coverage, high patient preference, and fewer critical errors with use. And we'll speak to why that's important over the next few slides. The efficacy and safety of this particular medicine has been demonstrated in a number of randomized controlled trials. In New Zealand, it's indicated for asthma, and you'll see there the age of 12 years and older, where a combination product is appropriate. It's funded as the 125 microgram medicine. The stronger 200 microgram fluticasone furoate is available only on private purchase. It's not funded by Pharmac. An effectiveness trial was carried out to see how well fluticasone furoate vilanterol would perform in a real-world primary care setting. And I think this Salford lung study in asthma has been a critical study for various reasons. It was conducted in the UK city of Salford between 2012 and 2016. Salford was chosen because it had a high level of electronic medical record communication between primary and secondary care, which meant that the data could be captured in a more real-world setting as compared to a more artificial randomized controlled trial where patients had to attend a study center often and were chased up by the study team. Traditional RCTs do represent a highly selected patient population. They're not truly representative of the type of patients we see in everyday practice. In fact, data shows that just 4% of the typical asthma patients we see in daily practice make it through the selection process to participate in a trial. And of course, this limits the generalizability of the results to everyday practice. And also, it's this 4% from the RCTs that form the basis of the GINA guidelines. Efficacy studies are what randomized control trials are. Effectiveness studies, such as this, where they're based in a real-world, more pragmatic setting, can potentially provide greater insight into the value of a treatment in a less controlled and a more real-world environment. Here's the study design of the Salford lung study. It was a year-long study with more than 4,000 patients, and patients were randomized to either fluticasone furoate vilanterol in the treatment arm or the other treatment arm of usual care. And the primary endpoint was to assess the ACT score at week 24. And this slide just lists the key findings from the Salford study. The first 2 points there highlight the importance of effectiveness studies in guiding management decisions in everyday practice. And this Salford trial has been innovative and instructive in defining the type of data which should inform the guidelines. And in fact, the 2 studies that we conducted here in New Zealand that resulted in the updated GINA guidelines, they too were real life studies. So we can be encouraged that more generalizable, more relevant trials are being conducted to give us information that we can be more confident about. Fluticasone furoate and vilanterol in this setting, which does certainly appear to be generalizable, was effective in improving asthma control as measured by the ACT. It also outperformed other usual care, and there was no difference in adverse events. We've touched briefly on the differences that fluticasone furoate and vilanterol offers, and we're going to have a bit more of a detailed review in the next few slides on how it achieves these unique characteristics. The search for molecules with increased potency and glucocorticoid receptor affinity and selectivity has led to the development of this molecule called fluticasone furoate. The molecular structure has a completed ring to it as compared to the fluticasone propionate, which we've been familiar with for a number of years. And it's this completed ring structure which binds more tightly to the glucocorticoid receptor site in the lungs. This tightly bound molecule is therefore retained in the target site of the lung for longer when compared to other currently used ICSs, with the resulting benefit of reduced dose, reduced systemic exposure, and less frequent dosing. And this is the concept of targeted potency that I think is exemplified by fluticasone furoate. One of the concerns raised regarding fluticasone furorate's high potency is, does it reflect an increased risk of toxicity or adverse effects? Fluticasone furorate's mechanism of potency through the tight glucocorticoid receptor binding results actually in a wide therapeutic window or index. This is the degree of separation between the effective dose that gives us the control that we want and that which causes increased systemic exposure. And because the molecule is released into the systemic circulation slowly, and it has a high first-pass metabolism with negligible oral bioavailability, the risk of toxicity is low compared to other ICSs at an equivalent dose. Tolerability, side effects, and adverse effects appear consistent as an apparent class effect across all the ICS and ICS-LABA agents. And in particular, the concerns regarding pneumonia risk with ICS use for asthma and COPD remain real and consistent across all ICS medicines. You may see in the slide there's a medicine called Relvar. Relvar is the UK-Europe brand of fluticasone furoate vilanterol. So it seems that we have a good molecule. How best should this be delivered to the target site of the lungs? Inhaler technique continues to be a challenge, and so device choice is as important as the molecule being used. Inhaler device errors are very common, and they may impact on the effectiveness of the delivered drug. You'll see from this graph results from a systematic review and meta-analysis that demonstrated an estimate of overall error rates by device type and evaluated the factors associated with inhaler misuse. Critical error rates, this is where there's an error that stops the drug being delivered to the lungs. Critical error rates were high across all devices, MDIs and dry powder inhalers, ranging from 50 to 100% for patients with asthma and 14 to 92% for patients with COPD. Those are big numbers and obviously of concern. The Ellipta device, which carries fluticasone furoate and vilanterol, seems to have advantages due to its simplicity and ease of training, which is also important in the clinic setting. Operation involves 3 simple steps. Open, the cover's opened by the patient to show the mouthpiece, and this activates the dose all in one single step. Inhale, the dose is inhaled from the mouthpiece and then close. The dose counter indicates the remaining doses in large, clear numbers, and a red flag appears when the number of doses remaining is in single digits, and it turns completely red when the device is empty. So we return to Carmen. You may recall that I asked myself what I could have done differently to better manage her risk of severe exacerbations. At the time, mepolizumab wasn't an option due to funding restrictions, and currently her eosinophils are not high enough at 0.3 to qualify. As well as focusing on her treatable traits of smoking cessation support, social stresses, and improving her allergic rhinitis management, we elected to change her to inhaled fluticasone vilanterol through the Ellipta device with regular education and technique checks. And so far, she's doing really well. Were she to run into further cycles of exacerbations, Carmen may well become eligible for mepolizumab, but so far she's doing well on her fluticasone furoate vilanterol inhaler. So to summarize then, there needs to be a focus on establishing all patients on an ICS as per the GINA guidelines. This is really important. The management cycle needs to be dynamic and team-based. Concordance recognizes a precision medicine approach with treatable traits and shared decision-making as being the standard we should be aiming for. Assess, adjust, and review that cycle. And the choice of ICS and device does matter, and time needs to be spent identifying the best option for patients. One size won't fit all, but as a result of high-quality effectiveness trial data, fluticasone furoate and vilanterol through the Ellipta device stands out as offering significant advantages of being potent, safe, and highly acceptable for patient use and adherence. So thank you for listening. I appreciate the attention, and I'm very keen to take some more questions if they are there, Grace.
Okay. So, is there any role for fluticasone furoate vilanterol in mild asthma?
When we are thinking about mild asthma, I guess we're also thinking about moderate and severe asthma. And in the New Zealand setting, we go through a traditional stepwise approach, which was mild asthma with short-acting beta agonist. Then, if that wasn't enough, stepping up to inhaled corticosteroid as a maintenance and PRN SABA. And when that wasn't enough, introducing a long-acting beta agonist into the mix, perhaps through a combination inhaler, and escalating the dose of the ICS to maximum. So I think by defining a mild patient, they probably haven't got to the stage of needing a combination ICS LABA yet. I would be suggesting that a mild patient should be looking at an ICS on its own with a SABA as a reliever, or looking at the option of the combination budesonide formoterol PRN.
And just sort of leading on from the budesonide and formoterol combination, are there any sort of direct comparisons between that particular formulation and the fluticasone furoate vilanterol with regards to use in studies?
I don't believe there have been any head-to-head studies comparing the two. Others who are listening may have some better information than me. I think the medicines are quite different in that the long-acting beta agonist that is formoterol has a rapid onset of action, and that gives it the opportunity to be used as a PRN medicine. The vilanterol doesn't have the same rapid onset of action, and therefore its role alongside the fluticasone furoate is for maintenance. And with the advantages that the fluticasone furoate confer, it gives room for improved control when being used as a maintenance approach.
Okay. Now, if we have an asthmatic that gets several episodes of pneumonia, what is the advice around ongoing management?
I think that as I had to do with Carmen, if somebody's not doing well, we need to take a step back and just rethink the diagnosis, the tests, and the role for further input. I think if we've got an asthmatic patient who's getting a lot of pneumonia, there's likely to be something else going on, and that person really warrants secondary level assessment and support. We shouldn't be fighting this battle on our own. I suspect the question may be about the role of inhaled corticosteroid predisposing somebody to recurring episodes of pneumonia. I think that that patient is at more harm from uncontrolled asthma predisposing to more pneumonia than they would be from an appropriate low dose of inhaled corticosteroid predisposing them to asthma, if you understand that subtle difference. But that particular patient, I would be very keen to be engaging with my secondary care colleagues for more assessment and management advice.
Thank you. Now, with regards to spirometry again, do you think it should be done in everyone? And also, what is the role of pheno?
Yeah, it's interesting. Pheno is still being developed to find its real place, I think, in clinical medicine. It's being widely used in research medicine. Interestingly, in our trials that I referred to earlier, its role wasn't compelling as an indicator of exacerbation risk. But I think that it can be very useful in differentiating between somebody with obstructive airways disease who happens to be more like a COPD patient than an asthma patient. So it helps with the diagnostic clarification. But as far as guiding management choices beyond that, I'm not sure about its role yet. Spirometry should be performed more often than we are, particularly for COPD patients, and that's outside the scope of this particular talk. But I think that we need to be reviewing spirometry readings for patients over a period of time, because things do change, and particularly where the diagnosis is unclear, as it was for Carmen, seeing what happens with spirometry over a period of time can just help to clarify what the diagnosis looks like. But I do think that if we've got access to spirometry, and if it's not available in your clinic, in your community, it may well be, and certainly in the hospital setting, it should be available. If you've got any asthma patients whose control is not ideal and you're just not sure about the diagnosis, getting some spirometry can be very helpful to clarify that.
Now, just thinking about that reassessment space, how long would you normally advise? So you've seen a patient and you've given some treatment. When would you bring them back?
Yeah, good question. There is some data that suggests that when you've educated a patient well with inhaler technique, it takes them 6 weeks to get it wrong and start performing some critical errors. 6 weeks. So according to that data, we should be getting our patients back 6 weeks after their education session with the nurse to review that and just to further entrench that. You know, I think the reality of clinical practice is we don't have the resources to be seeing our patients that often. With our step-up studies, that was a 3-month cycle. So we did our first ACT, followed that up 3 months later, and then followed up again 3 months after that, following the step-up. I would suggest that with any management change in medicine, that a follow-up within a period of 6 to 12 weeks would be appropriate.
Okay. Now, how would you advise someone on fluticasone furoate vilanterol with worsening symptoms, but they're not unwell enough to need oral antibiotics or oral prednisone? Sorry, I meant oral prednisone, nor antibiotics. What would you suggest there?
Yes, so the fluticasone furoate vilanterol is a once daily inhaler. Can't use it more than once a day. But if there are symptoms, breakthrough symptoms, and these patients are going to get exacerbations periodically, they would reach for their short-acting beta agonist to use alongside that. And then if they have an asthma action plan that they've discussed with their clinician and they've had a good concordant relationship, they'll be able to reach for that asthma action plan and have some confidence in following the steps that have been agreed to, which may well include adding in some prednisone, having a clinic review in this brave new world of virtual medicine that might happen to be through a video connection. But I think that in that particular case where somebody's on fluticasone furoate vilanterol once a day, their control's not great, they're using their SABA more often, they then get clinical review to assess what's going on.
Okay, just some commentary from the audience to also agree with you that there are no head-to-head studies to compare the budesonide and formoterol versus the fluticasone, furoate, and vilanterol. Now, just with regards to oral prednisone, how many days would you recommend if someone needed it? There's, I think, a couple of different schools of thought on this.
Yeah, the discussion that I've seen around this is short is fine. So 3 to 5 days is sufficient, and the same applies to antibiotic use. But particularly the question was prednisone, no more than 5 days, and there's no need with a short course like that to step down the dose either. So in an adult, 40 milligrams once a day for 5 days would be appropriate.
Okay, I think that pretty much rounds it up from us. I'll just have a quick look through to see if there's any last minute ones. Now, I'm not going to pronounce montelukast in asthma control.
Yep. You pronounced it perfectly, Grace.
Oh, thank you.
Montelukast is certainly indicated in New Zealand for use in asthma, where there in particular is a strong allergic component to what's going on. And I have a number of my patients, in fact, you saw that Carmen was one of those who uses the Montelukast alongside the inhalers. So I think it has a very real role. There are some there's data that suggests that there are some important adverse effects to be mindful of with this medicine. So we don't want to be using it in all of our asthma patients, but we want to be finding those who have significant perennial or seasonal allergic rhinitis, and that in turn drives the asthma issues, and they may well do well on the Montelukast. Okay,
one final question for the evening before we wrap up tonight. I know we've been talking a lot about asthma in the adult space, but often as GPs we'll see young children that come in. We have to start them on inhalers. So the question that I pose to you, what tips would you advise for us when talking to the parents of a child about the risks of inhaled corticosteroids when we are starting them on this particular medication?
Yes, so it's a very important concern for parents, with good reason, because of what they have heard out in the community space about steroids, but without good reason as far as we're concerned as clinicians, because the doses that we're using in children are low and very, very safe. We know that the systemic exposure to the doses indicated for children is very low. It's not completely without risk, but usually the risk is with the higher doses that are required. So I would spend some time, and again, this comes to the concordant therapeutic alliance that we establish with our patients, and it may not happen in one consultation, and it may take some time, and it may involve providing some resources and having an ongoing discussion. Just reassuring patients, providing them with the data to say that the doses that we're using in children are very safe. You know, as I say, high doses, there can be some impact on growth parameters, but that's really the exception to the rule. And I would suggest that any child who's needing to have the high dose inhaled corticosteroid should be managed in a secondary care setting anyway. So reassurance, there's extensive data to reassure us that in fact frequent asthma exacerbations, not only will they cause irreversible airway damage to their child, but those frequent exacerbations have a bigger impact on the growth parameters of the child than the inhaled steroid would ever have.
Thank you very much, Andrew. Well, that'll wrap us up for tonight. So thank you again, Andrew, for joining us, and everyone else out there, thank you very much and good night.
All right, good night, thanks.